Good morning friends, welcome to my channel Medix Tutorial. This is the second video of respiratory system and today's topic is embryology of respiratory system. First we'll see overview of lung development. Lung development begins with the formation of lung bud which get formed from distal end of respiratory diverticulum during week 4 of development. So lung development begins with the formation of lung bud which get formed from distal end of respiratory diverticulum during week 4 of development. Lung development mainly occurs in 5 stages. First one is the embryonic, second one is the pseudoglandular, third one is the canalicular, fourth one is the circular, and fifth one is the alveolar. You can remember these 5 stages by a mnemonic. Every pulmonologist can see alveoli. In this chart, you'll see the lung development and its 5 stages with its characteristic features and some important notes or some errors. So first one we'll talk about the embryonic stage, which lasts from week 4 to week 7. From lung bud, it get derived to trachea, then bronchial buds, then main stem bronchi, after that the secondary lobar bronchi and the tertiary segmental bronchi. So we can say that from lung bud to the tertiary segmental bronchi, the development occurs in embryonic stage. Errors at this stage can lead to the tracheoesophageal fistula. Please do remember, error in the embryonic stage leads to the tracheoesophageal fistula. What is it? We'll see it in next slide. Second stage is the pseudoglandular stage. It lasts from week 5 to week 17. From endodermal tubules, it derives terminal bronchioles, which is surrounded by modest capillary network. In this stage, respiration is impossible, which is incompatible with life. The third stage is the canalicular stage, which lasts from week 16 to week 25. From terminal bronchioles, respiratory bronchioles get derived. From respiratory bronchioles, alveolar ducts get derived. These alveolar ducts surrounded by prominent capillary network. Airways increases in diameter in this stage. Pneumocytes develop starting at the week of the 20, which means we can say that pneumocytes develop in a canalicular stage and the respiration capable at week 25. Fourth one is the secular stage, which lasts from week 24 to the birth, which means week 38. From alveolar ducts, terminal sacs get developed. Terminal sacs separated by a primary septae. The last one is the alveolar stage, which lasts from 36 week of fetal development to the 8 years old. From terminal sacs, the adult alveoli get derived. due to the secondary septation. In uterine life, breathing occurs via aspiration and expulsion of the amniotic fluid, which leads to the increased pulmonary vascular resistance through gestation. At birth, the air replaces fluid. At birth, air replaces amniotic fluid, and which leads to the decreased pulmonary vascular resistance. In this image, you can see here it's a fetal development in prenatal period and postnatal period. Here you can see the stages of lung development, and this is the time bar which is represented in weeks until birth or in uterine life, and after that it in years after birth. And here you can see the lung development occurring in each particular stages as shown here. So first we'll talk about the embryonic period. It lasts from week 4 to week 7. Then pseudoglandular stage, which lasting from week 5 to week 17. After that, the canalicular stage, which lasting from week 16 to week 25 approximately. And do remember, at week 25 of uterine life, fetus is capable to respiration, or the fetus lung can able to respiration. Please remember. Now the secular stage, it lasting from week 24 to the 38th week, or the up to the birth. After that, the alveolar stage, it lasting from week 36 to the nearly after birth up to the 8 years. So here is one more important point I would like to mention. From week 20 of uterine life, the surfactant developing start from week 20 up to the 8 or 9 years of birth. Got it? Here you can see in embryonic period, trachea is developed and it divided into left and right bronchi, as you can see here. After that, there are bronchial buds are developing from the bronchial buds in embryonic stage. Then bronchial buds are developed. From bronchial buds, the bronchi, secondary and tertiary bronchi are developing, as you can see here. In pseudoglandular stages, in canalicular stage, these bronchi getting widened in its diameter, so they are making passage for conduction of air smoothly. After that, these bronchi are getting nodule like, which will form alveoli in alveolar stage. As you can see here, these are the bits like structure which represents the alveoli, and it is surrounded by prominent of capillary network for the exchange of gases. Alveolar cell types. There are three types of alveolar cells. First one is the type 1 pneumocyte, second one is the type 2 pneumocyte, and the third one is the alveolar macrophages. We'll see it one by one. So first we'll talk about the type 1 pneumocyte. It is squamous and occupies approximately 97% of alveolar surfaces. It is thinly lined the alveoli, as you can see here. It is thinly lined the alveoli, and it is important for optimal gas exchange. Now we'll discuss about the type 2 pneumocytes. It is cuboidal and clustered, as you can see here. It is cuboidal and clustered, as you can see here in A also. It is cuboidal and clustered, and also we can say that type 1 pneumocyte is smaller in size as compared to the type 2 pneumocyte by seeing in this image. So we'll discuss two functions of the type 2 pneumocytes. It serves as stem cell precursors for two cell types, that is type 1 and type 2 pneumocytes. It proliferates during lung damage. Type 2 pneumocytes serves as stem cell precursor for type 1 and type 2 pneumocyte, and it proliferates during lung damage. Also, the second function, it secretes surfactant from laminar bodies. As you can see here, these are the laminar bodies which present in type 2 pneumocyte and which secrete surfactants. So we'll see the functions of the surfactant. So surfactant decrease alveolar surface tension, which leads to decrease alveolar collapse, which leads to the decrease lung recoil and increase lung compliance. Surfactant composed of multiple lecithins, mainly dipalmitoyl phosphatidylcholine, which known as DPPC, dipalmitoyl phosphatidylcholine. Its synthesis begins approximately 20 weeks of gestation, as we already mentioned in graphical representation of the 5 stages of lung development, and it achieves mature level approximately 25 weeks of gestation. Glucocorticoids is important for fetal surfactant synthesis and lung development. Collapsing pressure of alveoli is equal to 2 into surface tension divided by radius. Please do remember, the collapsing pressure of the alveoli is equal to 2 into surface tension divided by radius. So also we'll talk about the law of Laplace. It is applicable to the alveoli and have greater tendency to collapse on expiration as radius decreases. What is the law of Laplace? Alveoli have greater tendency to collapse on expiration as radius decreases. Got it? Now we'll talk about the alveolar macrophages. It phagocytoses foreign materials by releasing cytokines and alveolar proteases. Hemosiderin-laden macrophages were found in setting of pulmonary edema and alveolar hemorrhages. Please remember, hemosiderin-laden macrophages are present when there is pulmonary edema and alveolar hemorrhage. Now we'll see the embryological defects of respiratory system. The first embryological defect is conal atresia, and it is the blockage of posterior nasal opening. Please do remember, conal atresia is the blockage of posterior nasal opening. It most often associated with bony abnormalities of midface. It is most likely present as unilateral, which means the blockage of one posterior nasal opening, but when it's bilateral, means the blockage of both nasal openings represents an emergency and presents with the upper airway obstruction, noisy breathing, and or cyanosis, which worsens during feeding and improves with crying. It can be diagnosed by failure of passing nasopharyngeal tube and confirmed with CT scan. It is often part of multiple malformation syndromes such as Charge syndrome, which includes coloboma of eye, heart defects, atresia of cornea, restricted growth and development, genitourinary defect, and ear defects. Lung malformations. It includes pulmonary hyperplasia and bronchogenic cyst. So first we'll talk about the pulmonary hyperplasia. It is poorly developed bronchial tree with abnormal histology, which is associated with congenital diaphragmatic hernia, which is usually left-sided, and bilateral renal agenesis, which means Porter sequence. So, bronchogenic cyst caused by the abnormal budding of foregut and dilation of terminal or large bronchi. Discrete. It is discrete. The cysts are discrete, round, sharply defined, fluid-filled densities on chest X-ray, which looks like air filled if it is infected by pathogens. Patient generally asymptomatic but can drain poorly, which leads to the airway compression and recurrent respiratory infections. Now we'll talk about the club cells. It is a non-ciliated, low columnar or cuboidal cells with secretory granules. So what is club cells? It is a non-ciliated, low columnar or cuboidal with secretory granules located in bronchioles. It degrades toxins via cytochrome P450. Its function is it degrades toxins via cytochrome P450, which secrete components of surfactants, progenitor cells for club and ciliated cells. That's it. Neonatal respiratory distress syndrome. It occurs because of surfactant deficiency. So, surfactant deficiency is the main cause of having neonatal respiratory distress syndrome. Surfactant deficiency leads to increased surface tension, also which leads to increased alveolar collapse, which looks like ground glass appearance of lung filled. As you can see here in this image, it looks like a ground glass appearance. And the risk factors for this syndrome is prematurity, diabetes during pregnancy, which increases fetal insulin, and C-section delivery, which decreases release of fetal glucocorticoids, which is very important for surfactant development, and less stressful than vaginal delivery. Treatment of neonatal respiratory distress syndrome includes maternal glucocorticoid before birth, give glucocorticoid to the mother, before birth or exogenous surfactant for infant. Therapeutic supplement of O2 can result in retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. You can remember it by mnemonic RIB. R for retinopathy of prematurity, I for intraventricular hemorrhage, and B for bronchopulmonary dysplasia. It is associated with a therapeutic supplement of O2. And the screening test for fetal lung maturity is lecithin sphingomyelin ratio in amniotic fluid. It's in healthy person it's greater than or equal to 2, and for predictive of neonatal respiratory distress syndrome is less than 1.5. And the other techniques are foam stability index and surfactant albumin ratio. As you can see in this graph here, on this side it's a concentration in milligram in percentage, and here it's a gestational age. We can see that in normal or healthy person, as the gestational age increases, the ELS ratio increases, and the lecithin also increases, but this sphingomyelin decreases. As you can see the blue shading here, it represents a mature lecithin sphingomyelin age, which is normal for healthy person, as is showing it's up to 3, means greater than 2. And as you can see here in this dark shade it shows the atrix neonatal respiratory distress syndrome, as it's below the 1.5. Persistently low oxygen tension, it is a risk factor for a PDA, which is a patent ductus arteriosus. Here we done with the embryology and embryological defects of the respiratory system. The next video will be on the anatomy of the respiratory system. Thanks for watching. Do like, share and subscribe.